Mary is 72 years old with a diagnosis of a left hip replacement. She also has osteoarthritis, hypertension, and a history of urinary tract infections. She lives alone in a home in the suburbs. She was never married and has no children. However, her sister lives within walking distance. There are 5 stairs that enter her home and 12 stairs to the second floor where her bedroom and bathroom are. She's retired and enjoys playing cribbage with friends and volunteering at the town library. Prior to her injury, she was independent in all ADLs and home and community management. Her goals include being able to go home as soon as she can and to care for herself and her home independently. She also wants to be able to walk without a cane and be able to get up and down stairs without any pain. Mary is motivated to return home and go back to volunteering at the town library as she's worried story time will be canceled. Obstacles for Mary include arthritis, hypertension, history of urinary tract infections, living alone, stairs to enter her home, limited shoulder active range of motion, she can't make a full fist with her left hand, she loses focus sometimes, she's a risk for skin breakdown, and she doesn't want to use gadgets. A difficulty for me as a therapist would be getting her comfortable with using assistive equipment or gadgets during recovery. It'll also be difficult explaining to her that it's not a fast recovery and she can't overexert herself. Some precautions for her would include bending the hips past 90 degrees, crossing her legs, and twisting at the waist or hips. Some devices that she'll need when toileting include a raised toilet seat, self-wipe toilet aid, a raised seat with armrests, and a commode. A device for sleeping would be placing a pillow in between the legs or knees. However, she can't sleep on her stomach, and you don't want to put the pillow under the knees. Regarding doing ADLs, I would have Mary perform them while seated. I would also encourage her to utilize adaptive equipment such as a dressing stick, sock aid, shoehorn, and reacher when dressing. I believe Mary would have the most difficulty with dressing, as she was stated she does not want to use gadgets, even though they will help complete the task at hand. If she does not want to use adaptive equipment, I would suggest looser fitting clothing that she can wear to make it easier to complete dressing. I think she'd be able to prepare a meal for the most part. Her osteoarthritis might impact her ability slightly. For example, her shoulder has limited range of motion, which could impact her ability to reach for certain things in the kitchen if they're like on the top shelf. Her left hand is also unable to make a fist, which can make it difficult when performing meal preparations such as cutting vegetables. Social and leisure needs of Mary include playing cribbage with friends and volunteering at the town library. If Mary were to refuse using adaptive equipment, I would begin to offer her adaptations that would allow her to complete her tasks and reach her goals still. I would educate her that while these adaptations will help complete tasks, adaptive equipment would make it easier and that it's only temporary. One thing I would ask when determining what environmental adaptations might be needed for her is if she plans on having someone stay at the home with her for the beginning of her recovery. Another thing I would ask is if she has a walk-in tub or shower so that we can provide appropriate techniques. To try and reintroduce adaptive equipment to Mary, I would educate her on the benefits they would have for her, and I would show her how they are used so that she can see how helpful they can be during the recovery process. While Mary was referred to me for her hip replacement, I would like to still address her impaired range of motion and strength in her upper extremities due to her osteoarthritis. I would incorporate activities that could increase her active range of motion and strengthen the upper extremities. I do not think she is dealing with her transitional care unit placement well. She's become discouraged because she's not able to return to her own home as soon as she wanted, and when a nurse would go in her room, she either turned away or closed her eyes. She seems to be using avoidance to her current situation as an unhealthy coping strategy. A psychological concern for Mary when she leaves the transitional care unit is depression because she'll be unable to perform some of her daily activities the same as before. She will have to learn how to adapt, which can cause her to become discouraged and avoid doing the task altogether. I would see if there was a group focused on return to home tasks specifically for individuals that live in homes by themselves. A group like this would allow Mary to engage with other individuals that are in similar situations as her and could provide her some useful information for when she returns home. This group would also teach her new ways of completing household tasks that she may not have thought of before. It is important for Mary to learn the importance of gadgets or assistive devices when performing tasks, as I do not think she realizes how much they can benefit her in certain tasks. I would also go over post-hip replacement precautions with her, and another thing I would go over with her is the possibility for home modification depending on the layout of her current home. If I walked into the room and noticed a nursing assistant doing all of her self-care for her, I would ask Mary how she is feeling this morning. I would then ask the nurse to stop what they are doing while Mary and I talk. I would explain to Mary that she needs to perform these tasks independently as she will not have anyone at home to help her with them. If this were to happen again, I would politely ask the nursing assistant to stop so that I could ask Mary what was going on. I would ask Mary why she did not think she would be able to perform her self-care tasks. I would then again explain the importance of her performing these independently, since she will not have anyone at home to help her. If I overheard Mary telling her roommate I was a pain and doesn't like that I make her use crazy gadgets, I would not necessarily do anything right then and there, but I would remember to incorporate adaptive equipment education in the next treatment session. I would have a discussion with Mary on why she does not like using adaptive equipment, and then explain that while she may not like using them, they can make doing activities a lot easier, and I would reiterate that it's only temporary. If I noticed that she was not putting any weight on her left leg and she responded with, "I don't want to take any chances," I would tell her that I understand her concerns, but then also explain that she can put some weight on her left leg as it will help it heal. I would tell her that this can be a gradual process where each day or activity we add a little more weight to the leg. It's important to explain to her that applying weight or stress is going to help the healing and recovery process. If she cried out in pain when transferring, I would stop the activity and move Mary to her bed. I would ask her if she still feels the burning pain in her leg and examine her wound, and then contact a nurse and explain the situation to figure out the next steps. I would begin discharge planning when she has shown she can perform all self-care ADLs independently and when she can perform all transfers safely and pain-free. I would want Mary to be able to perform 75% of tasks independently that are needed to safely live in her own home. She will not have a lot of help around the house, so she will need to be able to perform most of these tasks. I would include Mary's sister in the discharge process if she were planning on being with Mary upon her return to home as an extra hand. Mary would play the role of the client or student as she needs to understand what is included in her discharge and what the next steps are. I would recommend Mary continue OT at home because it would be beneficial to have someone provide further services and possibly see her home and make suggestions for adaptations that would benefit her. A concern of mine, if she did not see an OT at home, is that she would lose independence by not properly engaging in daily activities. I would ask Mary to try one session before deciding she did not want it. I would explain the importance of still having an OT to be able to provide suggestions, as it would further the recovery process. I would also explain to her that OT in the home looks a little different than how she has been experiencing OT with me. Mary was independent in feeding and eating, grooming and personal hygiene, upper body dressing, and upper body bathing, as her injury mainly was to the lower extremity with a hip replacement. And she was considered MOD independent and supervision with lower body dressing and lower body bathing. And MOD assist for bed mobility was mentioned in the OT eval, as she was unable to roll without bracing for pain and needed MOD assistance to roll over in bed. Max assist was considered for bed to chair transfer and toilet transfer per her previous OT eval. And tub or shower transfer and ambulation need to be assessed at the next session. One thing to note is that the client was afraid to place weight on her left leg, as she was afraid of it popping out and going through it again. She also refused male nursing assistants and was hesitant to female care staff when dressing and bathing. One concern would be education, as she has a lack of interest in adaptive equipment despite being educated on all their benefits. Looking at the upper extremity, all sensation was intact and there was no visible swelling, so no edema was seen. The shoulder active range of motion was assessed as 2/3 range, and manual muscle was considered a fair minus. Elbow, forearm, wrist, and the right digits were all within functional limits. The left digits, however, were impaired as she was unable to make a fist, which also impacted her grip and pinch strength in the left hand. Coordination was also considered within functional limits as well as motor planning, and she reported pain, only slight pain, in the MCPs and the left hip during motion, which is important to note. Looking more at her lower extremity now, she had slight edema in her left lower extremity, and there was an incision from her hip replacement, and we would want to refer to PT during the recovery process as well. Her static and dynamic sitting balance were within functional limits. However, her standing static and dynamic balance where max assist was required, and which made her impaired for doing ADLs. She was afraid to place weight on her leg because, again, she was afraid of it popping out. She required glasses, but her hearing, communication, and cognition were all intact, and she was A&O ×4, which shows good orientation. However, she needed redirection to remain focused at times. Some specific mental functions where client had high level of cognition, so she was able to perform tasks that require executive function. Her memory seemed to be intact and sometimes needed redirection when losing attention when doing tasks, like I said before. For global mental functions, she was consciously aware of therapy session. A&O ×4 shows her orientation is intact. However, sleep was not addressed, so that would need to be addressed at the next session. Her communication was verbal and she was fluent, so it was easy to understand her. Emotional regulation, however, needs to be assessed at next session as well.